You should be.
Got it. Got it. Okay, let's start really quick, right fresh over. Thank you all for joining us for our series. This is part 2 of the series. Just a reminder, can everyone put their phones on mute? And we love having people on cameras if you want to join our fun faces and interact. And then also, please put your name and where you're from in the chat. And again, I am Nikki. I am the manager down here at Golisano Children's Hospital in Fort Myers for their transport team, but I am the president of the Florida Neo Pediatric Transport Network Association. And we have a bunch of speakers to come together, not from one agency, but as a state, to really come together to bring this education to you guys. Our first part was about OB and maternal pre-hospital emergencies. And today we're going to talk about the neonatal pre-hospital emergencies. We have a few objectives. We're really going to talk about the fetal transition, newborn resuscitation, and then stabilizing the premature newborn. So first up is Julie Bacon. She is the program manager, chief flight nurse at Johns Hopkins All Children's. She has been my mentor for years, amazing friend. She is a well-renowned speaker, and she just will keep you engaged. So Julie, it's all yours.
All right. Happy noontime, folks. We're going to start at the very beginning. And it's an interesting thing. Most people think that babies go from fetus to real people, but there is about 3 to 4 minutes when they're transitioning between the fetus and the real people world, where we can do interventions that really make a difference going forward and whether they're going to need resuscitated or not. So I love this one. For those that have a teenager, you understand. Turns out I'm a freeloader. So let's think about what is going on inside of mom. Okay, inside of mom, and I'm advancing my slides here. Inside of mom, baby has what they call fetal circulation. So let's think about the lungs themselves, because don't we think about primarily neonatal and pediatric? We worry about their respiratory status. So inside of mom, what are the fetal lungs doing? Think about that a moment. What are they doing? Who's doing all the oxygenating and all the ventilating and all the dumping CO2 for baby? Mom's doing that. So here are these lungs. I want you to think of fetal lungs like a teenager, okay? They grow, they suck up nutrients, they have no real purpose in life, but someday they're going to step up to the plate and do what they were intended to do. That's what fetal lungs are, because inside of mom, we know that mom's blood that comes in through the placenta, and tell me, Nikki, can you see my mouse when I'm moving my mouse? Perfect. When you see, I'm also admitting people, by the way. So when you have this blood coming into the cord to the baby, it's fully oxygenated. The CO2 is low. As it comes into the baby, it doesn't need to go to the lungs to have those things happen. So how do we avoid them going to the lungs? Just a couple of things real quick. We have bypasses, because remember, fetal circulation and congenital heart, they're really all about plumbing. So as we come in through the inferior vena cava, the two primary bypasses that we have in fetal circulation, one is the foramen ovale. Now in you and I, we have unoxygenated blood coming in from the inferior and the superior vena cava. Not in baby, remember, nice and oxygenated. So it's like, I don't really need to go to the lungs. So here I have this trap door right in the middle. And some of the blood is going to go from the right atrium to the left atrium. This is called a right to left shunt. And whenever you hear the words right to left shunt, I want you to think, right, I don't need no stinking lungs, to the left shunt. Okay, fatal in you and I, but part of fetal circulation. Some of the blood doesn't go through that trap door there. Some of it goes down into the right ventricle and then heads to the lungs. And again, only about 10% actually needs to go to the lungs to help with the growth of the lungs itself. The rest of it's going, I need to do a right to left. I don't need no stinking lungs shunt. So they find a second option, and that's the ductus arteriosus. Okay, you might have heard the term patent ductus arteriosus, in which that pipe stays open longer than it should. So these two primary bypasses are what is happening that is shunting 90% of the blood away from the lungs to the rest of the body. And then it's going to end up going back to mom for that O2 CO2 exchange. Obviously, once a baby is born, once that cord is cut, this needs to change, and it needs to change quickly. So here are, we're going to talk about the 4 primary steps of transition. And the important thing to remember is if one of these steps doesn't happen, that's when your baby starts to get into trouble. All right, so here's what, I can't see you on camera, but I'm going to trust you on this. I want you to get your hands out because we're peds and people, so we have to do hand motions, all right? And we have 4 hand motions, okay? It's in, out, open, shut. All right, I want you to do it with me. You'll thank me later. Ready? In, out, open. Gotta go faster, Chris. Shut. One more time. In, out, open, shut. What does that mean? Those are the 4 steps of fetal transition. So my first step is going to be what? In, right? In with what? Air. That's those first big, huge gulps, breaths of air there, right? Not weeny little breaths, not puny little breaths, not you ask somebody, is the baby breathing? And you look over and the baby's going, no, that's not effective, right? That doesn't count. We need big, huge breaths. That's why they used to hang them upside down and pound on their rear ends. Why do we need in with big, strong breaths? Because then the second thing is out. What's being pushed out? What's been filling the lungs so far? Okay, the remainder of the fluid that's in the alveoli needs to push out into the lymphatic system, push out, right? So you can't do that with you can't do that. That does not count. Big in, robust breaths, out with the fluid. That then, do you remember next step? Open, okay? 2 things are opening. Alveoli is opening. We need that to happen so we have CO2 exchange with the O2. And as that happens, what is O2? It's a vasodilator, and that pulmonary bed of capillaries that's been all clamped down starts to open up again. And as vessels start to open up, we've got pressure changes, right? So in with big hunking breaths of air, out with the fluid, opens up the alveoli, which allows the O2 CO2 exchange and opens the pulmonary bed. And finally, shut. What are we shutting? We're shutting down those plumbing bypasses. And that has a lot to do with the change in the oxygenation. It has some to do with the change in the pressures. But as you can imagine, if something interrupts one of that in, out, open, shuts, now you've got a baby that's in trouble. So what are some red flags that we're going to look for that's going to heads us up that we might have a problem, that we might need to intervene? All right. When we take a look at, how about no prenatal care? That's like a great big, beautifully wrapped gift from the Grinch, right? You have no prenatal care means I don't know the gestation. I don't know whether it's a multiple. I don't know if she's positive for things, if she's conveniently pre-medicated herself, right? I don't know what's going on. So anticipate the worst until proven differently. Multiple birth. If mom knows, yes, that I have a multiple birth or I have multiple complications, what does that mean to me? Greater chance of resuscitation, a need for more resources. Do I need to call another unit? Do I need to heads up a transport team? Do I need to call the NICU down to the ER? You know, something like that. Anything you can do ahead of time. If a parent has had good prenatal care, we might already know there's a congenital defect. And to be honest, a lot of prenatally diagnosed congenital defects plan to deliver in one of our children's facilities. But as we know, plans often change. Maybe the baby's born early, maybe there's a storm, maybe they can't get there, maybe they're on vacation. So you may be delivering in a place that's not optimal. And if mom comes in and says, guess what? I'm a congenital diaphragmatic hernia. I am an XYZ, you know to get your resources going. How about gestational age? Okay. Term being, you know, you're greater than the completion of 37th week. The earlier that is, the more resources, the more I'm going to need to know, where is my OB kit? Where is my bag valve mask for this size patient? Have I heads up someone to get an extra set of hands? Because in a let's call it a normal, uncomplicated, anticipated full-term delivery, I really should only have sort of one-ish patient, right? Mom should be doing okay. Baby should be doing okay. But if I know any of these other things are going on, I clearly have two patients. I clearly need two sets of resources. Do you have some of those days where meconium just happens? Yeah, I know you have that bumper sticker on your car. Well, meconium, if you think about it, is by definition the first stool that an infant has, that a newborn has. Imagine, don't want to be gross at lunchtime, but hey, we're medical. It's the accumulation of no bowel movement for 9 months. It's not pretty. It is disgusting. It is acidic. It is toxic. It is, it's something you don't want to suck down into your lungs. So there's two things I want you to think about with meconium, because we've all heard, oh, if someone says, oh, this is a meconium, and everyone goes, we need more resources. Absolutely, you do, for two reasons. The one we think of first is the fact that if the baby comes out and they have a lot of meconium and they suck it down into their lungs, there's just a lot of bad things that can happen. Increased chance of pneumonitis, ball valve trapping, increased pneumothorax, those things. But here's the other thing I want you to think about that we don't. The meconium happened before the baby was born for a reason, right? Crap happens for a reason. What happened in utero that caused this baby to prematurely pass meconium? We may never know what it is, but it wasn't good. It was a stressor. Maybe the cord kinked. Maybe there's a cord around the neck. Late decel, something like that. Just if the meconium happens, the first thing you want to think is, wow, this baby was in stress in utero and I don't know why. I may need to have my act together and get my resources. Secondly, when the baby is born, we are concerned whether they inhale and gasp that meconium down. So two things. The first one's really important to remember. We don't think about that as much. That is a red flag in itself that something stressful has happened. All right, make that go. There we go. All right, just a couple of things. Neonatal vital signs across the board. Less than 60 in a neonatal or pediatric patient that's symptomatic is considered to be bradycardic. Bradycardia is the most common lethal arrhythmia in the pediatric neonatal population. That's bad news. Here's the good news. We almost always know why it happens. The most common reason for bradycardia in this population is going to be hypoxia. As that infant, as that neonate's oxygen level starts to drop, the heart rate drops along with it. So if I have a baby that's bradycardic, my assumption is going to be that they're also hypoxic. So what do? If the most common reason for bradycardia is hypoxia, I grab myself some oxygen, not nasal cannula oxygen, not blow-by oxygen. If you're bradycardic, you are grabbing your trusty bag valve mask and you're giving oxygen. SVT is the other most common arrhythmia in children. As a matter of fact, we're the worst at EKGs. I mean, neonatal pediatric people, the worst. Do not ask us to look at an EKG. There are only 4 rhythms in my world: fast, slow, dead, and funky. Funky gets to go to the cardiologist. Dead is dead. And we have fast and slow. We don't end up with the 45 years of McDonald's French fry arrhythmias, generally in children that don't have congenital heart defects. SVT is greater than 220. And the thing to remember about that is, can you get a baby's heart rate above 220? Oh, you sure can. Take him away from mom, pull the plug out of its mouth and start an IV. Your heart rate is easy 220. But what happens when you give him back to mom, put the plug back, and you're now wrapping the IV? The heart rate goes down because it is environmentally controlled. In supraventricular tachycardia, it's not about the environment, it's about the wiring. So it's tacking away at 240, and you put the plug in his mouth and it's still 240, and you wrap him up and it's still 240, and it's nice and even. And the most common things that we do with SVT is, least invasive, is ice slurry in a Ziploc bag to the face, or adenosine. Those are the most common things that we do. And then remember that with a respiratory rate, we are looking at no greater than 60 breaths a minute, unlabored. Now, what is worse, too fast respiratory rate or too slow respiratory rate? Well, guess what? kids, neonates, the first thing they do when they get into respiratory distress is they try and compensate by breathing faster and then deeper and then faster and deeper until they get tired. And then they breathe slower. So if I tell you, well, you have 2 kids in the waiting room, 2, newborns that are 2 days, one is breathing 70 and retracting, and the other is breathing 8, grab the one that's 8 because they are just about to die on you. Here's a secret on blood pressures. First off, to use blood pressure, you have to have the right size blood pressure cuff. Okay, not always easy in the neonatal population. But here's your easiest way to remember. Your mean, you should have a way of having blood pressure, including a mean. Your mean should be at least the gestational age of the patient. So in this case, and if you got a chat box, chat me on it. On this case, if I told you I have a 35-weeker, ignore this part. We really don't care in a newborn, okay? Just look at the mean. If I have a 35-weeker, is my blood pressure too high, too low, or normal? Remember, it needs to be at least the gestational age. So 31 is my mean. My baby is 35 weeks. You a little worried about that? I'm a little worried about that. If I have a 35-weeker, my mean blood pressure on a newborn doesn't work on anybody else, guys. Have no idea why. Don't really know why it works on just on newborns, but we all use it. It should be at least 35. This is a hypotensive patient. Now, if I had a 27-weeker and my mean is 31, then I'm in a much better shape, right? Because it needs to be a minimum of 27. In the adult world, which I have never in 30 years worked in because they're big and they're scary. Same way people tell me neonates are little and scary. In the adult world, you grab your BVM when you need to code a patient. We need to change that mindset in neonates and peds, right? The bag valve mask in our world is an anti-coder. That is your magic wand to be able, if we know that bradycardia is going to be your most common lethal rhythm, then a bag valve mask attached to O2 to pull that up is going to be your way of turning the situation around. So when we talked about planning ahead, if you know you're going on an OB call, if you know you're in the ER, mom is, delivering as she comes through the door, it is critical to have the right size mask on hopefully the right size bag, but you must have the right size mask or it's not going to work. That's your anti-coder in these situations. Never hesitate to grab the bag valve mask and give some woof and puffs, okay? Worst that can happen is they just scream at you, but don't hesitate. Because remember, we've got in, out, open, shut. If my in is wimpy breaths, my out, open, and shut don't happen, and you have a very short period of time to turn that around. You in the bag, that's what does it. How about fluids and resuscitation? Okay, you've got a little longer transport, you're down in the ER. If you have a patient that you are bagging and you're looking at compressions, I guarantee you they're going to need fluids and you're going to need IV access, right? In pediatrics, we do 20 mLs per kilo. In the newborn and neonatal population, we are doing 10 mLs per kilo, okay? Easiest way to do that is remember, think how many kilos. So let's estimate full term, give or take. You're like, I don't have a scale. I'm in the back of a truck. What are y'all doing to me? Does a Brownlow tape work on neonates? No, it does not. So pull out your cheat sheet. You know what? You couldn't do algebra in high school. What makes us think we should be good at it in the middle of a code, right? Everyone should have a cheat sheet. If you don't, okay, remember, if it looks like a full-term kid, use 3 kilos. If it looks somewhat early, use 2 kilos. If it looks really early, use 1 kilo. That's your best guess. Take that times 3, and we're looking at 10 or 20 or 30 mLs of normal saline pushed in the first 10 to 20 minutes. So let's talk sugar, okay? We've done the first part. We managed their ABCs, but you are now in Central Florida and you are trying to get to the nearest hospital. And sugar is a huge thing because what ends up happening is, again, inside of mom is providing all the sugar for the fetus. But as soon as that baby is born and that cord is cut, then wham, the supplier is gone. There is no sugar whatsoever coming in. Why do we worry about sugar? Because the primary fuel to the brain is glucose. And if that glucose drops drastically, you may end up with a child who's seizing or who has neurologic deficit going forward. Now, term babies, in that last few weeks before birth, it's like visiting buy one, get one free day at Krispy Kreme. Man, they're just piling it on. They just pack it on their hips. They pack it under their arms. They're preparing. Those last few weeks before birth are really about preparing to transition to the outside world. However, what happens if your baby is premature? Okay. If they're premature, they haven't packed on those donuts, right? They're born without, because they should have been a mom. Remember, there's nothing wrong with a premature baby except where they're at. They should be in mom. Now they're in the outside world. Or a small for gestational age baby, which is one of those babies that's closer to term, but they look very puny. They look very emaciated. And it's probably because they've struggled for every calorie inside of mom. These are risks, okay? These are risk kids. I guarantee you they're outside, they're stressing, they're using the very small resources that they have. Their sugar is going to be low. Okay. And what about the other side? Your sumo wrestler babies. You go through the Target checkout and the National Enquirer says, baby weighed 17 pounds and walked out of mom's vagina. Probably not. Okay. However, we've all seen those huge, huge babies. If you respond to a call, if you're EMS and you respond to a call and the first word out of mom's mouth as she is laboring is, I am a gestational diabetic, here's what I want you to think. Gestational diabetics or diabetics tend to have very large baby. Insulin is a growth hormone, right? So these babies are very large. So if mom delivers the baby, do you think you might have an increased chance of some dystocia, some difficulties in birthing that baby because they're much larger than they should be for transition? So that is a huge red flag. So that's before birth, big red flag over this child having some problems in the birth process. Secondly, though, once they are born and they're used to having all of this sugar from a diabetic mom, and they have been putting all that insulin out because there's nothing wrong with the baby's ability to produce insulin, they're going to gobble up all the insulin in their body very quickly. And they are, quite frankly, the most difficult babies to manage when it comes to glucose. So two things, if you are trying to manage fluids on a neonate, on a newborn, two things. Number one, we have a resuscitation fluid, okay? We may need to bring it up. Number two, we need to provide fluid with sugar in it. So our maintenance fluid is going to be D10 on neonates. And the reason it's D10 is they worked out how much it takes, how much sugar it takes for an infant to maintain their metabolic. And it comes out to D10, right? If you need to bump up the sugar, you can use the same fluid, D10, and you just give 2 mLs per kilo. All right, thermoregulation, huge thing. Babies have, good news, babies have more skin per fat. Bad news, we as adults have more fat per skin. All right, lots of body surface area. We know that in peds, but it's even more exaggerated in the neonatal population. Why do we put hats on babies? Is there something magical about the head? Okay, here we're going to have an exercise. Everybody put your hands right up above your head like this, okay? If you are an infant, this is how big your head is as opposed to the rest of your body, right? They are proportioned differently. A lot of body surface area on the head. That's why it's important to keep it covered. Couple of tips. Hats, put a blanket over the top. Chemical assist, those would be the thermal warming blankets. Nothing microwaved, no hot water. It's difficult to regulate those, and it's very easy to burn that very, very fragile skin. All right, so I get to do a first case study. Hope those are some great tips for our neo population and our transition. This comes out of our EMS logs, and it's based on a true story. EMS is called to a home for a precipitous delivery. Bad day at the OK Corral, right? You'd rather have a whole busload of heart attack gomers golfing than one precipitous delivery. Unit shows up at the house, and they are met at the door by an adult male who in one hand is holding a bloody knife. In the other hand, he has a newborn with the guts spilling out, blood everywhere. He is literally babbling and incoherent. What does scene safety tell you? Get the heck out of Dodge, right? We have got a psychopathic maniac here. All right, as happens, because in this county, you know, they get a heads up, police, law enforcement comes also. They arrive right behind the EMS, like literally, they see what's happening in the door. The two of them run up, one grabs a baby, the other subdues and handcuffs the still hysterical, babbling adult male. They look at this baby with the guts hanging out, and they have a trauma alert to the nearest hospital. No one notices, by the way, no one noticed that there was a mom inside. Just fun facts to know and tell. They didn't find her until a little later. EMS arrives at the trauma center with their trauma newborn, which they assume psychopathic male has done in. And this is what they see at the trauma center. Now, in their defense, and as they have told me, why didn't anyone ever tell me there was this somewhat common congenital defect called gastroschisis? Poor dad, can you imagine? He delivers his wife at home, baby comes out, they had no prenatal care. This is what he sees. He used the knife to cut the cord. He is babbling incoherently. Let's talk about our first case study. This is a congenital defect, which means it's there before birth. To the right of the umbilicus, always to the right of the umbilicus, the abdominal wall failed to close. And so what should be in was able to leak out all of those months. So outside developing is intestines, potentially stomach, potentially liver. So what would we do? Knowing this, and I'd probably jinx someone for tomorrow, what if you were presented with this as a precipitous birth at home? Your abdominal contents are outside. The first thing to remember is our big ABCs, and don't fix what's not broken. Some of these kids are crying and pink. You would think that you should intubate people whose intestines are outside their body, but not necessarily. You're going to assess your patient. If your patient does need respiratory support, we want to avoid bag mask ventilation in this case. Why? Because if I'm using a BVM, if you are within the scope that you can intubate, you would like to try and intubate, because as we do BVM, we're forcing air down into the trachea, but the air is also going to migrate down into the stomach, and the stomach may be, and the intestines may be outside the body. And eventually we want to put all that back in, and we'd like not to blow it up if we have that option.
Oh, I got Larry.
So avoid the big valve mask. Decompress the stomach. Again, if it's within your scope, pop an OG tube down, and let's try and keep as much air out of the intestinal tract as we can. Bag your bowel. An older way of managing it is you would have like wet to dry, normal saline, that sort of thing. Take the plastic bag that your BVN came in. Put a large Ziploc bag in your OB kit. That's what I would advise, because you could use it for preemies and you could use it for this. Pull it up over the defect, and you now have sort of this greenhouse, because you're worried about warmth and you're worried about insensible fluid loss. Intestines leak a lot of fluid. So bag your bowel, pull something plastic up there, and make sure you're doing all of those other things we talked about to keep the baby warm. Prognosis, when you get them to the right center, actually pretty good. They take everything that's outside and they stuff it back inside, and these kids have a pretty great long term. I'm not sure I can say the same about the EMS crew that responded to this event. So with that, and Chris, I've got teaching tips. Teaching tips on this case. in a newborn. When your insides are outsides, that does not always equal trauma. And if something inside is now outside, think about the fact that it really wasn't supposed to be there. So let's cover our ABCs and then think fluid and warmth, the two things that you're going to rapidly, and that could be abdominal wall defects, that could be spinal defects. Think fluid and warmth when it comes to these kids. All right, case study number 2. I would like to introduce to you my friend, Chris Sorrell. He is the manager of the St. Joseph's Children's and Women's Hospital Critical Care Transport Team, doing pediatric and neonatal transports in Tampa, Florida, and also is practitioner in the emergency department at St. Joe's Tampa. I'm going to hand it over to you, Chris. I have the slides, so please let me know when you want me to switch them.
All right, thank you, Julie, for the introduction. Unfortunately, I am not near as animated as Julie is, so mine might be a little bored down after that great presentation she just gave. So my case study is based on a premature neonate. This is actually a call that I was on when I first started as a neonatal transport nurse. It was about 2017. So there was a mother that presented to an outside facility here in Tampa. She was having abdominal pain and contractions. She was at 26 weeks gestation at that time. She was seen in the emergency room and she was discharged home without any complications. She was told the baby was fine. The mom had very appropriate worries, but based on what the doctors had told her in the emergency center, she went home. She thought everything was fine. 21 hours later, mother continues with abdominal pain and contractions. She called 911 to just kind of report that she wanted to go back to the emergency room. However, that baby had other plans. So when mom went to go potty, as she was waiting for EMS to arrive, 26-week child then fell into the toilet at home. This was mom's first baby, first pregnancy. The cord was intact. When EMS arrived on scene, they did transport the mother, and the baby was now 12 minutes old. Came into the OB emergency department at St. Joe's Children's Hospital, Women's Hospital. You can go forward, Julie. When EMS arrived, they did cut the cord. They did exactly what's appropriate as far as NRP and stable, as far as being able to stabilize a baby. They did dry, they warmed, they wrapped the baby up in a blanket. They placed a hat on the neonate's head. Unfortunately, due to not very many people are experienced with intubating 26-week gestation neonates. However, they were able to bag the patient appropriately with appropriate, as Julie has mentioned, a bag valve mask with an appropriately sized mask for this baby. When they arrived into the triage area, or actually they were still in the ambulance at this point, the vital signs of the baby was a heart rate of 72. The baby was pale, the baby was mottled, and there was minimal breathing effort. As Julie mentioned, once you get down to that heart rate of 60, that's when we're going to start getting nervous. 72 to me is going to already get me clenching in some areas. That's going to make me think, okay, our trajectory is going downhill as opposed to uphill. I will also mention this was actually my patient. The baby was my patient. This was my first neonate. I hadn't even transported a neonate yet. I had just kind of come off of orientation. So myself and the neonatologist met the emergency crew in the parking lot coming into triage. When we did, we placed the baby in a bag, which is, it's kind of silly to think like that, but like Julie just mentioned, having that Ziploc bag or using the bag from the BVM, something that can really, really save this baby's life. It's going to get it warm. It's going to keep that warmth in. I was able to successfully place an ET tube in this child. I can't even remember how it happened or how I did it. Again, we've been trained to do these intubations. However, just it's flying by the seat of your pants at this point when you know this little peanut that's about the size of your hand needs a breathing tube. Fortunately, I was able to get that breathing tube in. The transport team was waiting. My teammates were waiting just outside of the ambulance. So we were able to basically establish that airway with an ET tube. We did place it into the transport isolate inside the bag, and then we rushed the baby to the NICU. Once we were in the NICU, we were able to give surfactant, which is something that we're not really going to talk upon on this conversation or these case studies. However, surfactant you administer down through the breathing tube. There's actually new ways that we're starting to do it now through a feeding tube down into the lungs, which helps to just, coat the surfaces of the lungs so they're able to oxygenate us at their best. So we were able to establish that airway. As soon as we did notice the heart rate was improving. It started at 72, we got it up above 100, and then we started to notice the modeling going away, and the baby was starting to turn pink. Go ahead, Julie. The mother was then taken to the emergency department where she was handed over to the OB on call. As Julie mentioned early in our talk here, a lot of us don't know what to do with the adults, so you don't want us taking care of your adults. None of my practices with adults, way too big and just way too scary for us. We'd rather have those 26 weeks gestation babies. The mother didn't really have any significant complications, just besides mental health and anguish from a traumatic, last 24 hours where she went to an emergency center. They told her everything was fine. She went home 12 hours later or 21 hours later, delivered the baby at home in the toilet. The mother was able to come to the NICU and, visit her baby, and mom was discharged within 48 hours after her birth. Good news, this neonate was improved without any major complications following the birth. It spent greater than 3 months in the NICU without any incidents. It never needed any vasoactive medications. It weaned from the ET tube and respiratory support to room air. One thing that we do worry about with all of our premature babies, especially in this 26, the 20 weekers and the late 20 weekers, is interventricular hemorrhage of the brain, just because those vessels aren't really fully developed yet. So there's really a big chance that they will bleed. And then, that leads to deficits down the road, any kind of learning disabilities, things like that. Fortunately for this child, there was no indication of any IVH. And the discharge, the baby was then discharged. It went home with some specialists. I think ophthalmology was consulted. I think we did send it to cardiology just because there was a murmur, which is a lot of times, most of the time, a murmur in a newborn, neonate, premature, whatever, it's harmless, it's benign. It's like what Julie mentioned with those pipes having to close right at the beginning of birth. Sometimes it doesn't happen like the textbook says it does, where those slam shut with that first deep breath. So you will hear a murmur in these babies. And again, as mentioned, a lot of times, even if it's a full-term baby and you hear a murmur, it's usually not indicative of any kind of a major complication. Hopefully they've had some prenatal checkups, and if there was a murmur noted or anything abnormal during pregnancy, they've already seen a fetal specialist cardiologist who's ruled out anything via fetal echoes and things like that. So happy to report at this time, the baby, I think when we wrote this, was 5 years old. I think he actually just turned 6 years old. Was in kindergarten, is doing well, no deficits whatsoever. The only thing that it does follow up on is with pulmonology, just for some BPD, and then it's followed by primary care. So overall, this child is going to have a happy, healthy, normal, long life. It started off scary as hell, and it made its debut, making sure everybody knew that it was here. However, this baby is doing completely fine, and it's now meeting all milestones and is being followed just by primary care. So a great outcome for what could have been an absolutely disastrous beginning. But due to the training and basically most of the things that Julie mentioned in her first part of the presentation about how you take care of these babies when they come out, this baby's doing just fine. And we can go on to the next, which is a case study. And this is going to be Miss Alicia Wolf. She has her BSN, RN, EMT as well, 17 years as a medic. She's the trauma quality coordinator. And with that, I will hand it part of Nikki's team down at Gallisano Children's. With that, I like that picture of the two of you. I will pass it on to Miss Alicia Wolf.
Thanks, Chris. All right, so like Chris said, I actually have a history as a medic, but I worked in labor and delivery as a nurse for a long time. And one of the things that I was lucky enough to be able to do is work with my mentor, Nikki. And we sort of helped develop the high-risk OB transport side of the transport team that we have at Golisano. So part of that kind of came from a case like this that we're going to talk about and sort of what initiated that. So in our area, we actually have several hospitals pretty close to each other, but one of them, the OB unit closed. So all of those services moved to a different hospital, making it a little bit challenging. Most of our EMS partners already knew about this, but obviously you get a lot of walk-ins, you get deliveries, things like that that are coming in. So it can definitely be a huge challenge. But this one was actually it's not as exciting as Chris's in the way that the baby survived, but this birth was supposed to happen at home with a doula. It was actually only about 5 minutes from the facility that EMS was able to transport to. But that was actually the one that closed their OB unit. So they were about 15 minutes from a hospital that even had a labor and delivery unit or a NICU. So transported by EMS to the ER. The baby, when they got on scene, mom had delivered part of the baby. Unfortunately, it was not the part that was supposed to come out first. Some of the reports were a little bit conflicting. So the body was delivered up to the head, or I'm sorry, up to the shoulders. And this supposedly had happened almost 20 minutes prior to EMS even arriving. The crew did it, absolutely the best that they could. And they went to the closest hospital because as a medic, I can tell you that if I pulled up on that, I would panic. It would not matter how far we were from any hospital. We're going to go to the closest one and just get help at least. But so they went to the hospital that had no OB services. There was an ED provider and then the nurse manager who were at the bedside. They were trying to contact an OB provider who was obviously not in house. I believe actually was not even working that day. But they were doing everything that they could to reach out to the resources that they knew that they had on backup. So when mom pulls in, baby's delivered up to the shoulders. They attempted McRoberts. They also tried to get mom into knee chest. Neither of them were working. They finally got in touch with the OB and the ED provider and the nurse manager and this OB doctor that were not in house were able to talk together and do an episiotomy via FaceTime. And they were able to get the baby delivered. They did attempt resuscitation, however, it was not successful. You can go to the next slide, Julie. So some of the things that we actually got out of this were, we did some more extensive OB training for EMS providers. I think as an EMS provider, most people know how to deliver a baby if they have to, not that they choose to, but they could do it if it's, more normal, if you will. But we did some extensive training on imminent delivery, abruption, hemorrhage, and a bunch of other things just to kind of help ease the PTSD, if you will, for those providers. Some of the other things that we did was we made sure that our outlying facilities had updated supplies and resources, like the warmers, the BOA packs, fetal monitors. And it's pretty nice. Our actual labor and delivery unit is able to monitor remotely, so we can connect any ER that's got the remote monitor to be able to help with moms that come in that are in labor. But like we said, we were able to develop the maternal transport team in addition to their NeoPeds team, which it gives a labor and delivery nurse transports with them, and it gives immediate access to a high-risk OB provider and an extensively trained nurse, along with the Neo team. So that was a huge help, and I'm sure a relief for some of these outlying facilities that go into panic mode when something like this happens. And one of the greatest things is that ambulance itself is able to transport mom and baby when feasible. Next slide. So a couple things that I wanted to just kind of touch on, like with mom, if baby's delivered up to the shoulders, what would be the first intervention that if you arrived on scene to find this partially delivered child, what would be your first priority? One of the things that you need to do is be aware of which hospitals do have your OB services, and notify whichever hospital you're going to go to, at least give them the heads up as soon as you possibly can. If you're calling dispatch and saying, hey, this is where we're going, please call them and give them a heads up. That way, when you do get there, they are at least a little bit more prepared. But the other thing is just to go ahead and follow policy. Keep the pressure off the cord, try to keep mom as calm as possible. And then for number 2, your priority for EMS for the mom, like I said, just keep her calm as if you can. Obviously, she's going to be panicking, but keeping her as calm as possible. And then, like I just said, make sure that you know which hospitals in your area have OB services. And if you can get to those safely, do that. But if you need to go to the closest hospital, just give them a heads up and let them know. And then just out of curiosity, I didn't know if there were other maternal transport teams in everybody's area that are able to transport mom and baby. Because I think that's a pretty cool little thing that we have here down at Golisano. But that was it for me. I know that's our truck.
Well, thank you, everybody. I don't know. I have not seen any questions come in the chat. Does anyone want to come off mute? Does anybody have any questions or comments? We have quite a few minutes here. Did we put you all to sleep? Okay. Well, if any of you are all still out there, oh, perfect. Thanks, Renee. Let me answer this really quick. So please, this is the QR code for your evaluation. This is how you will get your CEUs. Once we get all of this compiled, you will get it submitted. So please complete your evaluation. Renee says, just curious what you would do when a baby is stuck. Alicia, I guess I'll throw that back to you for a minute, or if Julie or Chris have anything to say to answer that.
So, okay, I will try and answer this as best as I possibly can.
Diesel fuel.
Yeah, exactly. Like I said, your biggest priority is going to not have mom push. No matter how you do it, it's not going to be pretty if the head is stuck, if you're unable to release that. It takes a lot of training, and there's only a handful of providers that I know of that are even comfortable doing it. Obviously, they do it if they have to, but they try to avoid that at all costs. Just helping the mom not to bear down is my biggest recommendation. Julie, do you have anything?
No, actually, from an OB perspective, I think you hit it, and your lane. From mine, I would say just remember that there are some factors. For example, if mom says she's a diabetic or something like that, where you're going to have a larger child. What if she says, I was due 2 weeks ago, right? Let's anticipate a larger child. In that case, maybe my thing is, let's haul to where is my nearest center that can handle this, right?
Yep.
It just gives you that heads up. So being aware that as the parents are giving you history, there is red flags that you can glean from that to help you out as far as resources and that sort of thing. It's a tough situation. I mean, it's really, there's not a good answer other than I love the don't push and diesel bolus.
Right.
To the right place.
So true.
Right.
Thank you. I see Matthew on here just asked if part 1 series was available to watch. So we are going to reschedule our part 1 because, as I almost forgot to do this time, I neglected to record series part 1. So we are going to hold it again soon, coming to a theater near you. We will get that rescheduled and posted out for everybody to sign up for.
And part 1 is the mom, right?
Yes. Yep.
It's the OB portion.
All right. The uncomfortable silence.
Oh, but great chats. Thank you all for chatting. It makes us feel not so alone.
Yeah.
That's the opportunity, but please take a moment and take the survey. It's really helpful.
Definitely.
Any other topics that you can add on the survey that'll help us prepare for potential next ones as well? We want to kind of continue this going on forward.
And that includes peds.
Yes.
So, all right. Thanks.
All right. I'm going to stop recording. Thank you, everybody, for joining us.
Alicia,
Thank you.